post-op hemorrhage, post-op seizures, etc., etc. But the thing that you need to worry about sometimes is after biopsies or after, um, uh, especially after incomplete resections, these tumors can bleed post-op. Because the best way to prevent post-operative bleeding is to excise the entire tumor. Because the normal brain is not as vascular as the glioblastoma. So if you leave tumor behind with the abnormal vasculature, they will there's a chance of bleeding, there's a chance of postoperative edema, something that people have called the angry glioma syndrome. Um, it's a very cheesy term. I don't use it, but it's described by a lot of surgeons, and it's in the literature. So those are the two things you need to worry about. So whenever you feel that your biopsy or your debulking will lead to an angry glioma syndrome or immense postoperative edema, which can sometimes be fatal for the patient. The only way to go about it is to debulk more, make sure you have complete hemostasis, make sure you don't leave abnormal vasculature behind, which can bleed later on. These are classical um, histological findings at necrosis, microvascular proliferation. uh, Lots of molecular pathological markers that need to be now done routinely. We do IDH, we do TERT-P, we don't do EGFR. We do P53 ATLX, 1P19Q. And the classic glioblastoma will be IDH wild type, retained ATRX, P53 mutant, and a KI index of more than 60%. Um, MGMT status is, we routinely do this. It has a very good prognostic indication in terms of how these patients will respond to temozolomide chemotherapy. And so if the MGMT methylation status, if the patient has unmethylated MGMT, then so MGMT, what it does is that it's a DNA repair in gene which um, so temozolomide will act by damaging the DNA. It's an alkylating agent, so it will damage the DNA in the cancer cells. And if the patients have MGMT, then they will repair the DNA. If the MGMT is methylated, then that repair mechanism is lost. So the temozolomide will be more effective. And you can see here that the methylation status as a response to chemotherapy, that when these patients have MGMT methylation um, positive, then their survival is much longer than about 2 year, 3 year, 4 year, and 5 year survival as compared to patients where the MGMT is unmethylated. So this is one of my patients with a methylated MGMT where we could only do a biopsy of the lesion, but look at the post-op CCRT response. The tumor is almost gone. And quite a few of our patients with this disease will respond very well to CCRT if the methylation status is favorable. And despite just debulking, these patients will survive for years just on adjuvant chemotherapy. Well, emerging biomarkers include liquid biopsies. We're doing a lot of that. Then there's circulating tumor cells, TPs, circulating tumor DNA, and microRNA. So we're also doing a lot of basic science research on microRNAs and their role in GBMs. At the moment, it's all experimental in the sense that there are some microRNAs which have shown up to 80% sensitivity in diagnosing, but it's still not good enough to replace an MRI scan for follow-ups and for surveillance. But there is definitely potential in this area as a for research. So this is the STOOP protocol that every center in the world will follow now. That these patients will, after surgery, will receive concomitant chemotherapy and radiation therapy. Temozolomide is given at 75 milligram per meter square per day per oral dose during radiation therapy, and the dose is changed after radiation therapy. Radiation therapy is, of course, planned according to where the tumor is and different things. Um, and then these patients are followed up with 3 monthly MRI scans to make sure to look at the response and if there is change in response, and then do differently. And there are other things that we'll talk about. So there are novel therapies. There is a lot of interest on tumor treating fields. We don't use it. We don't have it in Pakistan. But it's useful for the small recurrences, deep-seated tumors, previously diagnosed, of course. Um, and my friends tell me that, and there's literature to support that the results are fantastic. Bevacizumab, which is an anti-VEGF. It's there's definitely some role for recurrent tumors with a lot of hypervascularity, a lot of edema. It has been shown to improve progression-free survival, to improve symptoms. However, it has not been shown to affect overall survival. So patients become better symptomatic in terms of symptoms. The MRI looks better, but it doesn't affect the overall survival, and it's also expensive. Carmustine, well, Dr. Javeed will talk about Carmustine. He's using this in Malaysia now. Optune is a new technology where this cap is patients are required to wear these caps for the entire day for weeks, and very, very expensive, costs thousands of dollars. Not great outcomes. I don't see it becoming popular. Immunotherapy definitely has a role. Um, and it's something that we are very excited about. Let's see what the future holds. And then viral carriers and gamma knife. So that's the VEGF antibody. We use it, bevacizumab. It's available. As I said, it's expensive. It does affect, if you see here, recurrent baseline, recurrent GBM, and response to anti-VEGF. Same here. It does improve the MRI scan. It does improve patients' symptoms, but it doesn't improve the overall survival. That's a laser interstitial thermal therapy. We talked about this. So the ideal lesions are patients with recurrent tumors, potentially high risk for another craniotomy, with deep-seated lesions, thalamus, hypothalamus, brainstem as suitable targets. Photodynamic therapy is also emerging technology. We haven't used it, but this is something that we're eagerly following to see if there's a role for it in future. We follow up these patients with MRI brain with contrast, um, uh, and we use the RANO criteria to report these MRI scans as accepted criteria. These are the consensus guidelines for management of adult high-grade gliomas that we published last year, and this was circulated widely in the entire country. And these are consensus guidelines that we developed with the Pakistan Brain Tumor Consortium, which was started at Aga Khan Hospital in my department and involved almost every major department of Pakistan. This is more than 100 neurosurgeons from across the country, more than 40 centers across Pakistan. And these are the guidelines that we all came up with. So if there's MRI suggestive of high-grade glioma, early referral to radiation oncologist. Um, if the KPS is more than 70, then decide if it's elegant, non-elegant, decide if you want to do an awake craniotomy, maximum safe resection or complete resection, or if it's elegant, impossible to dissect, then just do a biopsy, but the treatment starts with the histopathology. If the patient has a poor KPS, then you just do a palliative care. Once you have histology, then the case is discussed in the neuro-oncology tumor board. We as a policy discuss every tumor patient, whether it's newly diagnosed tumor or follow-up or surveillance. Every tumor patient is discussed in a tumor board. I can't emphasize the importance of tumor boards enough. No brain tumor patient should be managed without being discussed in a tumor board. It has helped us immensely in becoming better clinicians, better surgeons, better researchers. Most of our research is now done with our colleagues in medical oncology and radiation oncology. We also hold tumor boards with national collaborators across Pakistan, with centers in Peshawar and Lahore and Quetta. So pediatric tumor board we do with all of these centers separately. Adult tumor board we do a national tumor board once every month. Our own tumor boards we do every week for adult brain tumors. We do every week for pediatric brain tumors. We do once every 2 weeks for pituitary adenomas, and then we do one for spine. So we're holding maybe around 20 tumor boards every month. And then we do a joint tumor board with Hospital for Sick Kids Toronto every month where we discuss our complex pediatric cases. So uh, I can't emphasize enough the importance of tumor boards, and I would invite the France Society to join us in one of in our tumor boards and bring their cases and see how we manage ours. I'm sure we'll both learn from each other. And every decision is based on the consensus from the tumor board. And if there's a consensus of resection, so if I do a post-op MRI within 24 hours, present to the tumor board, and my oncologist says, okay, you need to take some more tumor out. I feel that I can do it. Then I take the patient back to the OR and do it. But every decision is through the tumor board. These are my steps of surgery. I have 4 minutes and then I'll give the podium back to Dr. Javeed. But navigation I use almost always, DTI mostly, awake mapping sometimes. Intra-op ultrasound, it's available in the OR if I need it. I don't have to book it. It's right there. Never use an intra-op MRI. I sometimes use a CUSA, depending on where the tumor is and what I plan to do with it. My preferable incision is linear. I start with an internal debulking. I use very little bipolar. I try and find the plane between the tumor and the brain using a pen feed dissector. I do most of my dissection with the pen feed. Only if when the bleeding will happen. Most of it will stop as you dissect the tumor out. But if it's affecting your vision or if there's a lot of edema, then of course I will sometimes use a bipolar, but only minimally. Not carpet bipolaring, but it's just find the vessel that's bleeding and control it. Most of these tumors, bleeding can be stopped with just cotton balls and irrigation. And I continue with my pen-filled dissection. But otherwise, I do use a balanced bipolar to control it. I do a post-op MRI within 12 hours of surgery. We published the results that if you publish it, you do an MRI later, the post-op changes tend to be confused with the residual tumor. So do it as early as possible, and if you have to delay, just do not delay it beyond 72 hours. If the 72 hours have passed after surgery and you haven't done a post-op MRI, then it's perhaps best to just wait for 3 months and then do it. Otherwise, preferably do it within 24 hours. I discuss all my cases in the MDT. Thank you. And this is my email address.
Thank you, Shahzad. That was excellent talk, actually. It's beautiful talk. And we have a lot of audience all around. We have a lot from Malaysia, from Afghanistan, from Pakistan. Great talk. What we do is basically a little bit of I open the room for discussions to discuss these things because the GBM is after WHO CNS 5 to 2021. Basically, the paradigm totally shift. It's become totally different entity. And some of them, we discussed that basically the new shift, what was the change on that. The second one is after the discussion is basically we'll have a little bit for collaboration, what we can do with Afghanistan sites. So I'll give one questions. Basically, I'll put one question, then we'll ask the audience to keep their question just like for 5 minutes. So basically on this 2021 CNS, when they change, basically 21 entity has been changed, including there's no more any anaplastic grade 3, they take it away. So as you said, IDH mutations, IDH with some markers plus wild type. Does it change your practice, like how you treat before 2021 and after 2021 in terms of GBM? Because it's become much more molecular, not anymore histological. Shahzad.
Yes, and it's interesting you mentioned it. We were in Manila just a few days ago, and
Yeah.
I had the same discussion with Hugh Dufau, the prominent professor from Montpellier, France, and he said the same thing. So the classification has changed, but as surgeons, our approach is the same. So if so for us, the goal is the question that we have to ask is, does this patient um, need surgery? Yes or no? If the patient needs surgery, can I remove the tumor? Yes or no? If I can remove the tumor completely, I will do it. And whether it's a grade 3 or grade 4, if it's IDH mutant or IDH wild type, whether it's a grade 2 or grade 1, we know that the extent of resection directly affects survival, both overall survival, progression-free survival. It affects the response to chemotherapy, response to radiation therapy. So I will do it. If I cannot remove the tumor completely, then my next plan will be to resect as much as possible. And we know that this also directly affects the overall survival and the response to chemo and radiation therapy, regardless of what the molecular this thing will. The what it has the new classification probably has affected is um, our ability to uh, 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 to study these tumor better. So now
Mm.
we are able to classify these tumors differently. So we are able to analyze these tumors differently and be able to come up with the better prognostic indicators for these different types of tumors. But from clinicians, I don't think it has changed anything for us at all.
Yeah, in relation to just thank you. Yeah, thank you, Shadat. Because we do have a very huge, I mean, experience here in Malaysia. Then later I'll come. So I'll open any other one. Have a if you have a basically question, please on your cameras. At least Dr. Shazad will seeing you in a future meeting, any conference, and ask your question directly in regards to the GBM. Raise your hand. I think we'll pick you up. Or you can write down your question on the chat box. We do have Dr. Rashad and Mustafa. I think they can. Any questions? Shazad, I just want to ask if there's no more questions. I just want to keep on the discussions. You said the role of fluorescence here in Malaysia, we're using 5-ALA, leucoleulanic acids and fluorescence. Do you guys using in Aga Khan the 5-ALA or fluorescence?
No, so we don't use 5-ALA, and the reason is it's expensive.
Yeah.
But we use fluorescein. I've personally used it quite a few times. It does help, and there are many studies which show both 5-ALA, especially 5-ALA, but also fluorescein, to improve the extent of resection for both for high-grade gliomas, especially, not so much for low-grade. Um, my so my uh, uh, the real difference that these um, uh, um, agents will make are for tumors where you can't differentiate the tumor from the normal brain on direct microscopy, on the white light, on the microscopic light.
Yeah.
The tumor is easily differentiable from the normal brain, then these will have no use in my mind. My guide for extent of resection is not just what is visible on naked eye. My guide will be the navigation, the DTI, or when I'm doing an awake craniotomy. So even if I don't see any tumor there, but on DTI, I know that there's room where I can dissect a little bit more, even if it's normal brain. Or from an awake craniotomy, I know that I can, so example, it's a right frontal lobe. I've dissected a tumor. So I will rather go for a supramarginal resection. In cases where you want to do an internal debulking and you're not sure whether you can differentiate the tumor from the normal brain, then these agents will make a difference. So it's something that it's good to have. It's not essential. in my mind.
I'm not sure, I have one or two slides. I mean, I'm not sure how many audience have seen how the five hala will work. I have one or two slides. If you want, I'll just show to them basically
If you look
how
at the
you.
data, the data clearly
Yeah.
suggests that
Yeah.
a 5 ALA improves extent of resection.
Yeah, definitely. But basically, what was our experience here in Malaysia? He said MRI within 72 hours. I think it's almost impossible for us to get within 72 hours the MRI post-op for large centers. And that's basically the game changer. If you cannot get it, you don't know how it is. If you're getting after 3 months, basically the tumor was double of
Yes.
what we've done and everything. So that's really the catchy point. You have to be very careful.
So my practice is I get the MRI. So MRI machine here in Karachi, we have two MRI scanners in my hospital. They're very busy, but they become less busy after 8 p.m. or 9 p.m. So for all my brain tumor patients, they get an MRI in the middle of the night. That does
I see.
mean that the patient loses the sleep. They have to wake up for the MRI. But all these patients I operate in the morning get an MRI the same night. So in the morning when I come back to talk to the patient, I have the MRI report with me to discuss with them that, hey, listen, your surgery went well. We've done the post-op MRI. There's no tumor or there's a little bit of tumor, and we'll just have to, wait for the biopsy report and we'll take it further.
Sure. Any other questions?
Also, for not the same type, so for pediatric tumors, especially medulloblastomas, I don't extubate my patients. So after surgery, they remain intubated. They go to the ICU. They first get a post-op MRI, and only then they get an extubation.
I see.
That's my practice for all pediatric tumors.
All right. Okay. Any question from Afghanistan?
Dr.
Anyone?
Jomi, I think, we have Dr. Jomi. Maybe we can give him the mic.
Sure.
Then I will ask my own question. Okay.
All right. Okay, Jomi, sab. Mehrabani.
Hello, and how are you? Thank you for your presentations. I have one question that in the glioblastoma, when the astrocyte grew up, how they grew up in the brain, and how can astrocyte grow up and replaced by the normal brain tissue? Meanwhile, other tumors of the brain, when they grow up, they have their own mass, and we have brain also too. In glioblastoma, the normal brain replaced by glioblastoma. How this fact happen in the brain? And do astrocytes normally proliferate? And how does this relate to the development of glioblastoma? And how does glioblastoma replace normal brain tissue? And how does glioblastoma infiltrate and replace normal brain tissue? Thank you.
Yeah, so thank you very much for that question. First, it's a basic science question, if I understand correctly.
Yeah.
And like all cancers, glioblastomas come from the astrocytes, and they tend to grow with the white matter tracts. Um, uh, i- we have very early reports written beautifully by Professor Ghazi Yashagil, who has, despite not having a great educational background in basic sciences, he was able to determine, based on his experience with thousands of gliomas, on the pattern of growth of these tumors, and with his knowledge of microneurosurgery and white matter tracts, he was able to see a pattern of growth of these tumors on the pattern of white matter tracts, whether it's the frontal, temporal, and I must encourage you to read his text on how he has described the pattern of growth for these tumors. It's really a piece of art for somebody to write them in the late 70s, early 80s, before all of this technology and DTI and MRI scans. Is just fantastic to read those. We know that these are abnormal growths like all cancers, and they have a preferential growth that we see for different types of cancer, and that's why these tumors don't metastasize; they only grow locally grow. They replace brain tissues by mitosis, by abnormal unrestricted growth, and the growth is so fast that it exceeds the ability of the tumor to get new vascularization. Although new vascularization is part of the pathophysiology, so that's why that leads to the central necrosis at times, most of the times. So that's the tumor growing faster than it can supply, get its own blood vessels, and then that leads to the edema and all. The it doesn't always involve brain cells. Sometimes it only displaces them. Um, uh, at least earlier on in the disease, it starts with displacing tissue before it infiltrates it. And that's why on the basis of MRI scan, sometimes you can't say if the disease is resectable or not. And that's where it helps to use DTI and awake mapping to find out whether some of the tracks are just displaced or infiltrated. So even despite all our knowledge, we are not able to tell that for every tumor, the pattern of growth will be the same. Similarly, the it's and maybe there's more to it that we haven't understood, that we will understand with time. Similarly, if it involves the ependyma, the CSF pathways, there is a risk for drop mets. So if for like any other glial tumors, if there is involvement of the ventricles, the ependyma, the CSF pathways, you have to evaluate them for the entire neuroaxis for drop mets anywhere in the spine. So if there's leptomeningeal involvement, that's one thing that you can you have to expect, and if there are drop mets, then you have to include that in your radiation therapy. I hope that answers your question.
Thank you, sir. Thank you.
Thank you. Yeah, that was purely basic stuff. Yeah. Yeah. Go ahead.
I think so the whole presentation was totally amazing, and there were lots of things to learn, especially for the residents like us. And the one point which Professor Shehzad really emphasized on that, and there was also a big lesson for us regarding the tumor board meetings. I think we need to find a mechanism for that for Afghanistan so that we can do some national meetings. And then later on, we can collaborate and we can work with the Pakistan Neurosurgical Society as well, so that we can case or discuss our own cases. This is the first thing which was really eye-catching, which is very important, and so that I started to re-mention it again here. And the question is for me, so I know that Awafan is running different projects. We are also part of some of those projects. I think there's one Pakistan brain tumor epidemiology study. We are also working on that. We are also part of that. And there's another project with the German Cancer Research, I think somehow like that, regarding the pediatric neuro-oncology. Anyhow, there are lots of researches going on around the world. And despite of all the advances in surgery and radiotherapy and chemotherapy, so the overall prognosis of GBM is still very poor. The way the world is expecting to have a good prognosis, despite of all the money is going on and research are going on. So there is no favorable outcome for the GBM. So the question is what will be the next major improvement in the treatment with the GBM? Maybe it's coming from the genetic or molecular research level thing. Something maybe need to be changed in that level so that we can have a good conclusion after treatment. Or something need to be changed in immunotherapy, or whether there should be any breakthrough in the artificial intelligence that might change the outcome of the GBM. What do you think, Professor, that in the near future or far future, which of these mechanisms of these pathways will cause a major improvement in the outcome of the GBM?
Yeah. Thank you, Rashad. That's a very, very, very good question. And in my opinion, and I may be wrong. So there are different areas of GBM research. The first thing is the diagnosis. We used to call every high-grade neoplasm a GBM in the past. Even until 2021, we have redefined our definition for the GBM, right? So that tells you that we still don't understand if glioblastoma is one disease or whether it's a spectrum of diseases. So we're still understanding what the disease is. So that's one thing. A lot of research is going on. I agree. It's more than $1 trillion of research in the last 10 years, and no great survival benefit. So a lot of this research is on the diagnosis, on radiology, on molecular pathology, on microRNA, on liquid biopsies. A lot of this research is on surgery, on chemotherapy, radiation therapy. In my opinion, we've reached the end of our technical achievements in terms of surgery. We can't do any better surgery for GBMs except for whatever we are doing right now. It's not going to improve the outcome anymore. In terms of diagnosis, radiology, molecular pathology, that doesn't improve outcomes. Radiation therapy, I think we've reached the end where at least for the next 10 years, there's nothing on the horizon. As you see for the rest of the cancers of the body, the radiation therapy is not changing. There are no new, to me, the only thing that can be a future game changer, as we have seen in lung cancers, for example, or for some other cancers like blood cancers. Immunotherapy may have a future role that can completely be a game changer. And I hope for a day when for GBMs we have enough radiology technology that we diagnose it on radiology, or we do a liquid biopsy. We just get a sample from the patient's plasma. We diagnose that this is glioblastoma, IDH mutant, or the ATRX negative, positive, whatever. And just based on the serum and the radiology, we are able to start immunotherapy that will completely dissolve the tumor. There should be no need for surgery because, of course, we've seen this for the last 20 years. Surgery is not making a difference. We can improve the extent of resection, we can improve outcomes by 3 months, 6 months, but that's it. That's not a lot. So I think like lung cancers, for certain lung cancers at least, I think immunotherapy is something that will develop. There's now a lot of research on using oncogenes and viruses to directly attack the tumor, customization of chemotherapy for each GBMs. And there's also interest in what is it? It's well, it's but immunotherapy and nanotechnology to deliver chemotherapy directly across the blood-brain barrier at the tumor bed. So those are the things that will change the outcome, not surgeons, I must admit.
Thank you very much. Thanks.
Excellent. Thank you.
The sad part is, and there's a discussion on it. So there's just been an FDA approval for a drug that reverses IDH mutants, IDH, and it's got an FDA approval. It took $3 billion of research to develop that drug. Now that drug is out. It may have a role, it may not have a role, but that drug is costing at least $100,000 per patient per year. Now, even if that drug works, how long will it take for the people from Pakistan and Afghanistan to be able to afford that drug for 1 year of benefit? You see? So my fear is that immunotherapy will come, it will benefit patients, it will get an FDA approval. For the first 5 years, our patients will not be able to benefit it unless they can afford it, unless they're politicians, unless they are smugglers. So we will only afford it when the FDA opens it up and it becomes affordable for low-income countries.
Perfect.
Thank you. So Shahzad, I just want to bring a little bit of this discussion furthermore, because there's a lot of surgeons sitting from Afghanistan and furthermore. I mean, there's two things I want to discuss. I'm coming to surgical complication. So basically, GBM is most of the studies shown that in a best first world and everything, the outcome is basically if you do total getting 1.5 year, maybe 2 years. We had 1 or 2 patients. Basically, I had one patient actually he lived for 5 years. And what's happened to that when we take out the bone? And he's got like horn on his head, and the GBM is growing like this. And other day, one surgeon from Afghanistan also called me. He said that one guy is like also the bone was out. They take out the bone, it's like coming up. This is one of the complications which I tell. I think it's disease which is not curable. Instead, if you want to make like help, I think the bone, if you're putting there, I think if you will die peacefully, but it will be all of his life will be miserable. I'm not sure do you have that experience or not. The second thing is if a patient's coming in Afghanistan, low resources countries with the GBM diagnosed with GBM, what's your advice based on your experience? Like, you know, like it's ethical or it's things that's they'll be operate then without temozolomide or chemoradiotherapy, what will be the outcome, not operate? What's your strategy if you're being in that kind of situation?
To answer your first question first, well, the risk of complications are significant. I agree. I mean, the mortality rates for GBM surgery is less than 1%. Morbidity is around 5 to 10%, but minor complications, major complications you can avoid. For recurrent GBM, if you operate, the risk of stroke is almost 25%. Some series report up to 50%. Small to medium-sized strokes can happen in up to 50% patients when you're operating for the recurrent GBM because there's so much adhesions. The vessels are abnormal vessels are so undifferentiable from normal vessels. So the stroke risk is high for recurrent GBMs. So one has to be careful. Taking the bone flap off, we've managed a few patients who, in the heat of things, the surgeon took the bone flap off and the GBM started growing. So if you have an intact patient walking around with a herniated brain, that's maybe acceptable. But imagine a comatose patient with a KPS of 40, 30, 20 with a herniated brain, and that patient is not going to die and the patient is not going to be useful. That life is not useful for the patient or the family. So that becomes quite a painful situation. And you can't put the bone flap back on, you can't resect the tumor, and it can't help the patient in any way. So sometimes that becomes a very painful condition, both for the family and the physician. The patient, of course, will never know. So sometimes the tumor will only grow outwards, but most of the time it will not only grow outward, but will also grow inwards. So we'll have a comatose patient with the herniating brain, who just refuses to herniate and die. The second question is about the rationale for the debulking surgery without chemo and radiation therapy. I still think, well, and there's a lot of data that adequate debulking surgery is also proven to improve survival, even without chemo and radiation therapy. It's not ideal, but remember the diagnosis of GBM is based after the surgery. So unless you operate, you never know you're treating a GBM, really. So even if you don't, and in fact, there's previous data which shows that even steroids improve outcomes, improve extent of survival, improve length of survival. So steroids improve survival, surgery improves survival, chemotherapy more, radiation even more. So even if we can't offer chemotherapy and radiation, I still think that as physicians, we can help our patients by debulking the tumor as much as possible, keeping them on steroids and hoping that they find a way to get chemo and radiation therapy. If not, at least you have done whatever was in your hands.
That's right. Yeah, I think that's the best. I think I totally agree with you. I think that's the best we can do, because we face this kind of situation in Afghanistan quite frequent, and the doctors basically they don't know this dilemma: operate, not operate. It's very fast growing tumor. The issues basically, I think whatever they can do, they do it, and the rest is basically, I think, let it go. All right. Any other questions?
We get our temozolomide from two means. One way is we import it from the US, which costs a lot. The other way is we smuggle it from India, and it's cheaper. But
yeah, India's very cheap, yeah, India is cheap actually. Generic one is also getting, Malaysia also getting from India because the thing is very expensive.
Yeah, so we can't get we don't have relations with India. We can't import it from India, so we have to smuggle it. But you know, it's good for our patients, so we use it.
All right. Okay. Good. Any other questions? Any other questions? So if it's no more questions on GBM or something, so I'll just push to this discussion. I think Dr. Pirzad is here as well. So I just want to just like a little bit push it to the second strategic plan for what we can do with Aga Khan's from Afghanistan point of view. In terms of, you mentioned a lot of good stuff, and Dr. Rishad also said about tumor board meetings, this kind of academic like publication, research. In Afghanistan, basically, it's like an unhidden kind of data there, actually. It's a lot of 6-7 hospitals not being published so much. We push from this side. So what you can do, then I think I'll ask Prof. Pirzad is here, is the president of Afghan Neurosurgical Society is here. He add on something else. What we can do actually, if we can improve this collaboration with Aga Khan in specific, what do you suggest? Shahzad.
You're asking me or
yeah.
Dr. Ahmad Fawad?
Ahmad Fawad will come. You just say what you can suggest and what they need, basically, they say. Or maybe, yeah, you just get what's your, yeah.
My request will be that I would like to invite our senior colleagues in Afghanistan to come visit us, come spend time with us, be our visiting professors, spend a week with us, see what we have, and let us know if what we can do to help you. But you have to come see us and to find out if what part of our and we've hosted many people from the US, the Canada, the UK, from Africa who've come and spend time with us. We end up learning more from them than they from us. But unless you come to visit us, you will not know if what are the things that we can help you with. And of course, we would also like to come and visit your centers to see where exactly can we focus our collaboration on. So there's lots of things we can do. First thing is training. We have a simulation lab that we've developed. It's a low-cost simulation lab. So a lot of things that we can do in that lab for under $100 that you would normally pay $5,000 in the Europe and the US to do. So we have simulators for spine surgery, from brain surgery, from intraaxial brain surgeries, for drilling and craniotomies that we can help develop in Afghanistan. We have a basic science research facility. I don't think as low-income countries, our focus should be basic science research. We should focus on education and training and improving patient outcomes, not basic sciences. Let the US or the UK or France and Germany worry about that. So the other thing we can do is we can initiate exchange programs. The young senior residents or the junior faculty members can visit each other's centers and learn from each other. We can have a data sharing agreement where we can collaborate on each other's data. We have a big team of researchers who can come visit, who can collect data, who can help you analyze it. We are part of many consortiums which can help train your researchers into dealing with your own data. We have research workshops we hold in Aga Khan, which we can hold for people, your teams in Afghanistan, to train them in data analysis and to make the best use of whatever you have. With technology now, with Zoom and Microsoft Teams, we can do tumor boards together. We can exchange cases together. We've done twinning programs with the Sick Kids Toronto. We have twinning program with the Great Ormond Street Hospital in London, where one of our colleagues has gone there to get a fellowship, and their surgeons, we invite their surgeons to operate here. We have collaborations with centers in the US, the Vanderbilt. We have centers in Africa where we collaborate routinely. We have an alumni network across Pakistan where we routinely do tumor boards and exchange information, and we go there to operate, and they come to us for observerships. So we already have a system where we exchanged all of these with other centers. We can, whatever you want to do, come visit us. Let us know how we can help you. We have the precedence to do it. We will do it in every possible way we can.
Thank you, Shahzad, for this generous and very, very well elaborated things. We do have in Kabul, if I may say, French mother and child kind of thing. It's also belong to Aga Khan. I think it's
FMIC, yes.
Yeah, FMIC.
Mm.
Yeah, that's we run it up. Prof. Pirzad, if you want to make it like concise, like if you want to say something.
Assalamu alaikum wa
Alaikum.
rahmatullahi wa barakatuh. Thank you, Professor Shahzad Shamim and Professor Javed Khan Rashad, Dr. Seb Burhani, all of our colleagues. Assalamu alaikum. Thank you very much. It's excellent presentation and excellent achievement. It was so nice that we saw your opportunity also, and I make also notes about your facilities. But unfortunately, as you know, we are a lock border, and it's very difficult to get visa from Pakistan or India or another countries with facilities. And Afghanistan, unfortunately, we previously had radiotherapy, but nowadays and during the war times we lost everything. And also chemotherapy is expensive, and as you mentioned, some agencies imported the chemo for oncology and for chemotherapy, especially temozolomide. It's expensive, but they are imported from India. And we, unfortunately, we haven't a good lab that's to see the quality of the medicine, and because sometimes it's smuggled to Afghanistan as well. And we do operations. We do operation, sometimes resection, totally resection the tumor, and you know that the recurrent is very we have a lot of recurrence and do sometimes recurrent surgery, and do, as Dr. Javed Khan mentioned, decompressive craniectomy as well for to make a bed for patients' benefit. But unfortunately, we also have difficulties with our OT, ICU. We haven't neuro navigation system in Afghanistan, and Dr. Rashad witnessed that we use ultrasound during the tumor surgery and other surgeries. And the quality of ultrasound also, unfortunately, not good. And I make notes about your tumor board, and I will contact with you that's to make connection with your team and your guidelines as well. And because the training and coming to Pakistan because of political issue, it's unavailable, and we would like to make a through virtually meetings with you and with your teams. But unfortunately, in these days, as maybe you know, you hear that the smart phones are not allowed for academic and for hospitals personnel as well, and it's unfortunately not good. And when we come to out of the university and hospitals, we can use our phone, and not allowed smartphone in the hospital and the university as well, unfortunately. And that make we we are very unsafe, and but tawakkal to Allah. Thank you very much.
That will get for you the smart glasses. You know, you don't need any more phone. You need smart glasses. You know, the Google one. They don't know about that one. Yeah, that's the solution. Okay. Then you can talk on that.
And we will also. I make notes that to Ikadien, and we see if Ikadien Aga Khan Development Network can help with us and to connect with you. It's also a good idea. Thank you very much.
Absolutely, sir.
Thank
Okay.
you. So I think I proposed, Prof. Pizat, I think you said let's look to the positive impact of this, because this politics and everything, they're changing every day, one day one. Let's look what we can do and what we take benefit from each other. So I propose, Shahzad, if you can get Afghan neurosurgical sites from your site, and you can get FIMC, the French and mother and children, get, I think we have one Zoom meeting basically, then they can push the politics and government to sort it out, or visa, whatever. But I totally agree with you. If you have resources, if someone is going so far away, why not the next door? Like we don't need to go because this visa and everything. So we will find a way to basically to copy your model, like what you have done. Afghanistan actually need a lab for stimulation as well, for training and all these things. If they invite from their side, they come and have a look. If they can copy that one in Kabul, or if we're inviting you actually, and now President is here, we just on their behalf, I can invite you, just come to Kabul, basically give them some ideas how to a low-cost kind of simulation training lab will be how it will be. Then we can work on that. We just
I agree, and that's the simplest thing, and the one with the most long-term benefits. And it's not an expensive lab to build.
yeah, because once we cannot go on your side, but I think I make sure that you can come to our side. That one we can.
I think we can, because we have the FMIC. We have a very frequent travel from AKU Karachi to FMIC, and there are lots of people coming. For even for dinners, we meet a lot of people from visiting from Kabul.
Yeah, I think should be okay. I think that one we can find a common ground for this one. So that's wonderful. Actually, that's really good. Shahzad, I'm really thanks for your all this honest and gesture kind of things.
It's been an honor. It's been a pleasure. But thank you very much for inviting me.
No problem. So if there's no more question, I think we have this one as we already record the sessions. We can keep it as a record. Then I think we audit it. Then you can put it things. And this discussion we just put it on YouTube and Facebook as well. And there's a lot of other medical students, specialists, residents all watching. It was really good talk. And thank you. And we will hope to having you in the future as well, Shahzad. Thank you very much.
It's been a pleasure again. Thank you very much.
Thanks.
Thank you.